Είναι ιδιαίτερη χαρά μου που συμπροεδρεύω σε αυτό με τον αγαπητό μου φίλο τον Ηλία τον Αθανασιάδη. Και νομίζω ότι υπάρχουν αρκετά θέματα τα οποία έτσι με πολύ ενδιαφέρον θα συζητήσουμε σε αυτή τη διάλεξη. Ηλία, the floor is yours.
Βασίλη, είναι μεγάλη χαρά να είμαι μαζί σου τώρα στο τραπέζι. Είναι χαρά μου να είμαι στην ΕΧΕΜ. Θυμάμαι πάντα τα πρώτα μου συναντήσεις της ΕΧΕΜ ήταν τόσο παλιές που αγωνιζόμουν να αποδείξω την αξία της αγωγικής θεραπείας. Και τώρα που πήγα στο ίδιο βήμα μετά από καιρό, λέω: έχει αλλάξει ο κόσμος. Και είναι ωραίο πράγμα αυτό. Η ΕΧΕΜ είναι πολύ δυνατή. Στην πράξη βλέπω τόσο κόσμο, τόσο πραγματικά είναι πολύ πλούσιο συνέδριο και η ειδικότητά σας είναι πολύ πλούσια. So, saying that, it's again my pleasure and my privilege to invite Dr. Kronevet, Ralph Kronevet. It's actually your fourth year here in the meeting. Actually, you appreciate your traveling here to be physically with us to exchange all these opinions. I think that the scientific material is going to be extremely interesting. Just from a brief discussion, I believe that this is a developing world, and the molecular tests are that a major part of breast cancer that the molecular tests are part of the staging system, which is unheard for a molecular test. So I think that you are going to describe the topic, which is going to be the clinical value on to predict, so you can detail on that.
The micro? Yeah, now it's working. Yeah, thank you very much for this kind invitation, and I'm really happy to be here again to continue this tradition, and now again in person, not virtually like last year. So, and now this nice weather here in Athens, so I really enjoy it, and thank you very much for the invitation.
I did not mention that you are in the Department of International Medical Affairs, and you are the leader in Myriad, who is sponsoring the events. So happy to be here with you.
Yeah, thank you. Yeah, so it's also my pleasure that I can start, that I have the first presentation in this session on gene expression testing. This is a topic that is already, I think, discussed for several years, but now, as you said, it's part of the staging system, gene expression testing, and I want to start to present the EndoPredict gene expression test, and I would like to focus a little bit on specific subgroup of patients that can be tested. But let's start here, and I think this fits very well to what we have just discussed. So in the last 30, 40 years, the determining prognosis and also prediction of therapy effects evolved. So for many years we had the clinical prognostic factors, which are still very valid. Then a new type of biomarkers came into the market, the first generation gene expression testing. There's MammaPrint and Oncotype. They also did big prospective randomized studies showing that these type of testing works, and then 10 years later the second generation gene expression tests came into the market, EndoPredict and Prosigna. They also have prospective trials ongoing, which are still ongoing since they came later to the market. And then the question is, this is what we discussed before, what comes next here, and what can add important information to what we already have here in the last years. Just for those who are not familiar with EndoPredict, a quick summary of the key features of this test. It's a 12-gene expression test predicting risk of distant recurrence, but also predicting absolute chemotherapy benefit in patients with ER-positive, HER2-negative primary breast cancer. So since we came later, we started later with the development, we could really focus on the target population here. ER-positive, HER2-negative breast cancer, early breast cancer, node-negative and node-positive disease. So for that type of cancer, this is optimized. And then EndoPredict was also the first test that that did not only assess gene expression, but also clinical factors were included in the final test result. Tumor size, nodal status, then 2 risk categories, low, high risk. And this was also, EndoPredict was the first that could be run locally. So the samples do not need to be sent out to other countries, to the US, and it is also a CE marked test confirming with all things associated with this CE IVD marking. So the concept of the test is that on the one hand, gene expression signatures measured in FFPE tissue reflecting the tumor biology, but also clinical parameters like tumor size, nodal status, which reflect the tumor mass. And both together provide the most accurate prognostic information. And the result is the so-called EPIC-Lin score. With an increase of the EPIC-Lin score, there's an increase of the risk of distant recurrence within 10 years without chemotherapy. And the cutoff was set at 10% risk after 10 years. And also an important point to mention here, this cutoff has not been changed since the first development. The same cutoff was used in all clinical validation studies that have been performed so far. This is just a quick overview how the test is run in the lab. So it's very easy, very robust technology based on RT-qPCR. So one section of FFPE tissue is necessary, RNA is isolated, RT-qPCR, and then the test result report is created. And this can be done in 2 business days. So there's a quick result, and it is run also in Greece at Biotriaki laboratories here in Athens. And it is also reimbursed in Greece and in Cyprus. So the test result is designed that it supports clinical practice. So as you know, when primary breast cancer is diagnosed, we have at the very beginning the decision on chemotherapy, yes or no, and after 5 years there's a decision whether endocrine therapy should be extended. And EndoPredict provides with its test result answers to 3 important questions for the support of these therapy decisions. So at the beginning, what is the risk of recurrence in the next 10 years? And also what's her absolute benefit from chemotherapy? And both information support the decision on chemotherapy, yes or no. And then a third information is provided, namely the risk of late recurrence, 5 to 15 years. So based on this information, the decision can be made whether the patient is fine without extension of endocrine therapy. So this is the result report from a typical patient tested with gene expression testing postmenopausal, G2, high ER expression, borderline Ki67 with 20%, 1 positive lymph node. And then the test result provides here the EPIC-Lin score and the EPIC-Lin risk class, low or high risk, and then 3 specific information. This is a 10-year risk of distant recurrence without chemotherapy, 6% here, 2% absolute chemo benefit, and 5% risk, 5 in the years 5 to 15 without extension of endocrine therapy. So this is one of the main validation trials, ABCST 6 and 8, 1,700 patients treated with endocrine therapy only. And what we can here nicely see, patients classified in low risk and high risk. So the low-risk patients have an excellent outcome without chemotherapy, without extended endocrine therapy, up to 15 years. As analyzed here. So 4.5% recurrence risk after 10 years and 6.6% after 15 years. We also did an analysis whether EndoPredict is able to predict chemotherapy benefit. This was an approach developed by Jack Cusick and Ivana Sestak in the UK, and this was a trans-cohort analysis including 5 study cohorts with 3,700 patients. Parts of them have received endocrine therapy only, the other part endocrine therapy plus chemotherapy. And the PREDICT was run on those patients, and we can see here the EpiClin score. The blue curve are the patients without chemotherapy, so increasing EpiClin score, increasing risk. The red curves are those patients treated with chemotherapy. And what we can see here, in high-risk patients above the cutoff, the red curve is substantially below the blue curve, and this is the absolute chemotherapy benefit, which increases with increase of the EpiClin score. And below the cutoff value, there is almost no difference between chemo and no chemo. And the test for interaction, the statistical test to show predictive power, was significant. And these data were recently acknowledged by the ASCO 2022 guidelines that came out earlier this year. So now the question is, who should be tested with a gene expression test like EndoPredict or also with other gene expression tests? I think this is a question that was also discussed since those tests came into the market. Which patient should receive a test? Let's have first a look at the clinical guidelines. So here I have an overview of international guidelines recommending EndoPredict. These are the 2 American, ASCO, NCCN, St. Gallen, and the European ESMO guideline. And what we can see here, and they have a consistent recommendation, meanwhile, that gene expression testing should be done in node-negative disease and in node-positive disease, 1 to 3 positive lymph nodes. They are not yet consistent with regard to menopausal status. I will come to this point later. But there is a consistency, node-negative and node-positive, 1 to 3 positive lymph nodes. So there was, for years, there was a reluctance in foregoing chemotherapy in node-positive disease, and that's why also in the early days of gene expression testing, those tests were also only recommended for node-negative disease, but meanwhile node-positive. And I just want to show you the EndoPredict data in node-positive patients, which really supports or which are the basis for the guideline recommendations. So here we have 3 studies assessing node-positive disease, 1 to 3 positive lymph nodes. Austrian study here, the Trans-ATAC study, a British study, and premenopausal study that the PI is from Cyprus, Anastasia Konstantinidou, which was recently published in Clinical Cancer Research. And what we can see here, consistently, these are postmenopausal patients, premenopausal patients, node-positive. EndoPredict identifies a group of patients, 20 to 35%, who are fine with endocrine therapy only after 10 years. So none of those patients have received chemotherapy, so those are safe without chemotherapy if they were classified as low risk by EndoPredict. Recently at San Antonio 2021, and a paper is meanwhile submitted, there was a prospective randomized control phase 3 study called UNIRAD, where EndoPredict was assessed prospectively. So 731 patients clinically high risk, node positive, 1 to 3 positive lymph nodes. All here, the limitation here is that all have been treated with chemotherapy. However, the result was highly significant, as you can see here. Patients with epiclin low risk, node-positive disease, have had no recurrence after 5 years so far. This prospective randomized study confirmed previous data on node-positive disease as well. And another important point that was analyzed, or what was an outcome of this prospective study, was in a multivariate analysis, the epiclin score compared to nodal status, grading, and tumor size was the only significant factor, prognostic significant factor, showing that the epiclin score provides added value prognostic information to the other factors that are already known as prognostic factors. And now just one comment on the node-positive disease, because I think this was one of the steps forward with the second-generation tests, which were also developed for node-positive disease, is especially in a node-positive situation. And there was one head-to-head comparison between a first-generation test, Oncotype DX, and EndoPredict, the Trans-ATAC study, published by the group of Mitch Dowsett in UK. They directly compared EndoPredict and Oncotype, and the green, the curve, the solid, this curve is epiclin low risk, 5% after 10 years, recurrence score low risk. The patients did well in the first 5 years, but then there was a drop in the later stages down to 25% of distant recurrence, although classified as low risk. And at that time point, the old recurrence score cutoff of 18 was used. So with the new cutoff at 25, one might speculate that this curve is even worse here. But this is one of the advantages of the second-generation test, including the clinical factors and adapting the genes to the node-positive disease as well. So now, next point, premenopausal patients. A few years ago, premenopausal, there was almost no discussion whether gene expression tests should be performed in pre or postmenopausal patients. But after TAILOR-X and R-Responder, we saw that there might be differences between premenopausal and postmenopausal, that probably the cutoffs need to be adapted, or that premenopausal patients benefit from chemotherapy anyway. So, and this is a reason why premenopausal situation is now so much discussed, especially after our R-Responder trial. And we did a specific, dedicated premenopausal study, and to my knowledge, there is no other study where dedicated study on premenopausal patients was done. And this, as already mentioned, the PI of this study is Anastasia Constantinidou, who usually is here, but probably this year she could not. But this study was published in Clinical Cancer Research in 2022. So 385 patients with premenopausal ER-positive, HER2-negative disease, up to 0 to up to 3 positive lymph nodes, up to PT3, and all patients received endocrine therapy only. So none of the patients had chemotherapy. And the samples were retrospectively tested with EndoPredict, and the primary objective was to assess the association between epiclin score and 10-year risk of recurrence. And so the median age was 46 years old, 16% were node positive, and there was a very long follow-up of 9.7 years median follow-up. And the results look like we have seen in the curves before, very good. So all patients, these are the patients, all patients classified as low risk, 2/3, have an excellent outcome after 10 years of 3% distant recurrence without chemotherapy. So EndoPredict also works in the premenopausal situation, and I don't think that a chemotherapy benefit can be expected in this patient group of 3% recurrence risk after 10 years. And they also did subgroup analysis, node negative, node positive disease. So the node positive subgroup is small and not sufficiently powered. But still, you can see here the node positive patients without chemotherapy classified as low risk. 20% of those patients had no distant recurrence after 10 years without chemotherapy. And another interesting analysis was done in this cohort, namely analysis by ovarian function suppression treatment, yes or no. And so those patients with ovarian function suppression had this result. These are the patients without ovarian function suppression. And as you can see here, there is no difference. So with or without ovarian function suppression, if EndoPredict says low risk, then patients actually were at low risk. So also this is an exploratory analysis. We need to be careful, but one might speculate that if patients are low risk, they are actually low risk with or without ovarian function suppression. And yeah, so that I think this was also a very, very interesting analysis coming out of this study. And so taken together these studies, and I think here we can see here, there are consistent results with the same cutoff value in premenopausal patients, in postmenopausal patients. Always, if the risk classification is low risk by EndoPredict, then you have a very low risk of recurrence that supports foregoing chemotherapy in those patients, because chemotherapy benefit in these recurrent rates cannot be expected. And also San Antonio 2021, there was also a small study with 99 premenopausal patients prospectively assessed, 43 years. And they did a follow-up of so far of 4 years, but in these 4 years, low-risk patients had with a low-risk EpiClin score had no distant recurrence in the first 4 years. Of course, we need to get a longer follow-up here. So what about other criteria like Ki67 grading and histologic subtype? And let's start with Ki67. I think you all know this is a debate since years. First on the cutoff value of Ki67, and the second about the reliability and the reproducibility of this marker. And recently, last year, a publication came out from the International Working Group Ki67 with a lot of important pathologists. And what they said, what they wrote, and was they confirmed that there is a limitation based on the analytical validity of this marker. There was a consensus that if Ki67 is below 5%, then no chemotherapy should be given in ER-positive patient. If it's above 30%, chemotherapy is indicated. So they gave a clear threshold guideline, chemo yes or no, but there is still between 5 and 30% a big gap. And for this, they recommend a multi-parameter gene expression testing in patients between 5 and 30%. And this was confirmed by the St. Gallen Consensus Conference last year. So that's a kind of guidance with regards to Ki67. When we look at the data of EndoPredict, so in one of our validation trials with 1,600 patients, we did a sub-analysis in Ki67 low, luminal A-like. The cutoff was 20%, and high, and what we can see here, in both situations, the gene expression test provides additional information. So here, 30% of patients that are high risk also being luminal A-like, and here 30% of patients being low risk, also being luminal B-like, and again, none of those patients received chemotherapy and were safe without chemotherapy. Yeah, and the same holds true for grading. So from the guidelines, there is no guidance with regards to grading, how grading should impact the indication for gene expression testing. But what we can see here, that independent of the histological grade, EndoPredict still identifies the low-risk patients which are fine without chemotherapy, even in this group of grade 3 patients. After 10 years, no recurrence without chemotherapy if EndoPredict classifies as low risk. And finally, histological subtypes. So we always got the question, does EndoPredict also work in lobular breast cancer? And there was a combined analysis in ABCHG6 and TransATAC published by Ivana Sestak. And what we can see here, this is the low-risk patient, lobular and ductal or NST, and there's basically no difference if you test lobular or ductal carcinoma, the same results with EndoPredict, so a test can be used in both situations. Yeah, and I just want to mention that we have 2 ongoing prospective trials in Germany, the rescue study, which has completed recruitment this year, which is in follow-up now, and then the UNIRAD study, where I've already showed you the 5-year results, and this will now be follow-up up to 10 years. So we need to still wait until we have the results of these big prospective trials. But what I want to mention is that this year in San Antonio, and those of you who will be there, please visit us at the poster. We will have 2 posters. Oh, sorry, there. And here, especially the second one, will present new prospective data on EndoPredict. So, yeah, you're welcome to visit us there at the booth and also at the poster in San Antonio to see this new exciting data. So to summarize, EndoPredict reliably identifies patients with low risk of distant recurrence who can safely forgo chemotherapy, regardless of nodal status, menopausal status, Ki67 and grading, and histological subtypes. I don't want to say that all patients should get a test. That's not true. But if you are unsure about chemotherapy decision, then EndoPredict can be run in all these situations in case there's uncertainty. If there's certainty from your perspective, then of course a test is not necessary, but in case of uncertainty. Then EndoPredict predicts chemotherapy benefit, predicts early and late recurrence up to 15 years, which helps in the decision on extended endocrine therapy, and it can be run locally in the country with a turnaround time of 2 days. So, thank you.
Thank you very much. This was an excellent lecture, giving us much of information and a lot to discuss about that.
Yeah.
So this is, I think the floor is open for discussion. Any questions or comments? Kyrios Nasioulas, Mr. Nasioulas. Microphone, please.
Yeah. Thanks for the talk, Dr. Kronenwet. Morelli, actually, you state clearly that is a prognostic test. However, through your talk, you give the idea that perhaps is a predictive test that can identify patients who benefit from chemotherapy. I don't see those data because in oncology meeting we have, the trial showing these patients, they have benefit from chemotherapy and these they don't. I haven't seen this data, but I missed something. What I'm saying is, it's a prognostic test, but you don't extrapolate that is a predictive.
Yeah, so you are right. All the tests, and this also includes Oncotype, have been developed as prognostic tests to identify low-risk group that are fine without chemotherapy. Afterwards, a couple of studies have been performed with Oncotype, showing that there might be a benefit in the high-risk patients with some limitations at the with those studies. But there are studies implying that high-risk patients have a benefit. But that's why I said all the tests are prognostic tests, but have shown afterwards that there is also predictive value. And we have shown that. I've shown this slide where with those two curves, patients with and without chemotherapy, and I can go back if we want, where it became clear here. This is that there is a benefit. So these are patients without chemo, these are patients with chemo, and there is, if the patients are at high risk, we have a shift of the curve down, which shows that there is a benefit, while the low-risk patients don't have a benefit, and there is a significant test for interaction. So these are the data. This was also confirmed in a prospective analysis in Germany, which I have not included in the presentation. EndoPredict has shown that it is predictive, in addition to its prognostic value.
I can see the predictive nature of these curves here, and also I think that about the lymph node positive patients, which is the tough bench, this is there. As long as you can show that there are 10-year results at the area of about 4 to 5%, I think they're at least clinically useful. This is the point. I mean, I understand that these distinctions between prognostic and predictive is very important, but also the question of what is really clinically useful. So I believe that you have, it was unheard that for patients with breast cancer, lymph node positive, premenopausal, you would not give chemotherapy. So if I see Anastasia Konstantinidou, I'm going to tell her, no, I cannot do that. So if she tells me that for this group, that I have 10-year results, 4 or 5%, and a good number of patients, yeah. I think that I cannot really have argument for offering them chemotherapy. So I don't know what I would do with everybody of them, but you don't change your habits right away. But all these patients, if they want to forego chemotherapy, they can do that because the floor is very close. So,
Yeah, exactly.
Thank you very much for your excellent presentation. I would like to ask the audience. Let's say that we have a patient, 35 years old, with 2 positive nodes, who is going to use this EndoPredict test instead of chemotherapy. I can see only 1, 2 hands, 3, 4. I will wait for another 5 minutes if I can see more. I think for the moment, we are not convinced about the usefulness of this test for node-positive premenopausal patients, according to the audience.
But I think we should ask who uses EndoPredict and who of them uses for the premenopausal.
No, what I'm asking is in a multidisciplinary meeting where we have a patient with 2 positive lymph nodes, grade 2, 35 years old, with Ki67, let's say 12-15%, who is going to use this test? 5. We need more data. What I'm saying is that we need more data to be convinced about the usefulness of this test in this particular group.
I think that it's not easy to change what you're doing every day, especially if it's on strong data. So in the beginning with Oncotype, I was familiar with Oncotype much earlier than other colleagues. I mean, I'm most close to the people who developed that. So there was a patient, actually, I still remember, where I was probably the only man in Athens saying that she would not have chemotherapy. She did all right. I mean, looking back, she was exactly at the limit, but she was all right not to have chemotherapy. Now, for lymph node positive premenopausal patients, it's not easy to change your habits right away. Yeah. It just goes on study. So I don't think that with this study, this has changed. I know Anastasia Konstantinou, I'm going to talk to her. I'm going to go to your paper. Actually, with all this information, don't run right away to the literature. So, I mean, follow your lecture. I'm going to open this clinical cancer research and see that. Yeah. But you have to be conservative, because when you have a recurrence in a patient with this lymph node positive disease, I think you should be really aware that you have strong data. Yeah. So I think that your data are convincing as a paper, it's clearly, and I trust the author and the authors obviously, but I think that to change your habits, you need something more, and this is reasonable to understand for Definitely. Everybody, for surgeons and oncologists.
Yeah, that's why we also have this ongoing prospective trial, so we will get more data on that, and also premenopausal patients, positive, are in those studies, so yeah.
Great, thank you very much for your talk.
Yeah. Congratulations for developing the data, and thank you all. Thank you for...
Επειδή είμαστε μισή ώρα πίσω, νομίζω ότι εντάξει, μπορούμε να κάνουμε συζήτηση για πολλή ώρα. Να καλέσω στο βήμα τον κύριο Κοντό και είναι και ο κύριος Τζανίδης αριθιακά για να προεδρεύσει στην επόμενη session, στο οποίο και αυτό προβλέπεται ιδιαίτερα ενδιαφέρον.